we'll have a discussion on basic concepts which you need to work in ICU. Okay. So my first question, Zishan, how will you evaluate? You have a patient in ICU, and how will you evaluate? The patient is on ventilator. So generally, what are general principles by which you will evaluate a patient in ICU?
So evaluation of a patient in ICU.
Yes.
Okay.
How will you assess daily progress or betterment or whatever? What will be the way that you have a patient in ICU? First of all, what will be the things which you will see in a patient when the patient arrives in ICU? This is one thing. And how will you see the progress, or what things will you assess? Will you give in information about ICU patient?
Okay, sir. ICU patients will be in ICU due to some kind of
very good.
An advanced disease process.
First question will be, I'm sorry. The first question will be that why the patient admitted.
Why the patient is.
Okay, so this is one thing. Wonderful. Okay, so it may be usually, what are the usual indications of patient being admitted to ICU?
So there are many like sepsis, pancreatitis, ARDS, PAP.
Okay, so if you want
GBS.
to grossly divide it, the reason may be this one.
Infectious?
No. The reason may be medical or surgical. You can grossly divide it, medical or surgical. This is one thing. Acute condition or chronic condition having some exacerbation. Okay, so you can just divide it. So then there will be some systems involved. So what may be the systems involved?
So respiratory system, neurological system, cardiovascular system.
Okay, mainly.
Mainly these three are the main concerns. Then renal and liver and GIT, all of the systems could be involved also.
Okay. So so this is one thing. So you should be knowing what may be the admission criteria for a patient in ICU, like any systemic decompensation, cardiovascular system decompensation in the form of some arrhythmias, ischemia, infarction, blood pressure going very high up, blood pressure going very down, respiratory system, respiratory insufficiency, problem with the any problem in ventilation or anything like that, any neurological decompensation, any electrolyte imbalance, any metabolic decompensation like Addisonian crisis, like diabetic coma, severe hypoglycemia, mixed edema. So this may be the reasons of ICU admission. So there will be some reasons for admission or in the ICU. Zahid, can you close your camera? Your camera is on. Thank you. So this is one thing which we will be thinking. Then what parameters will you see in a patient? Like are there some scoring systems by which you can start having that this patient is having high risk and this patient is having low risk? How can you?
Yes, sir. There are certain scoring systems like Apache, QSOFA, SOFA, and
usually what parameters we see in these scoring systems?
We see the CVS, we see the respiratory system, we see the nervous system, we see the renal and liver abnormalities.
Okay, and what else you do? That usually you take a baseline score, and then you follow the progression with its going up or going down. Okay.
Yes.
So and another answer will be that there are some specific scores. Okay, and there are some generalized scores.
Yes, sir.
Okay, like this SOFA.
These are the generalized ones.
Yes, SOFA,
Apache, these are generalized ones.
This is generalized. Okay, and if you talk about this Ranson criteria or Hansen has
are scoring Ranson.
Okay, so there will be some. So you can have a big list about it. because in our
Yes, sir.
this discussion, we will not be able to discuss each and everything, but I'm just trying to give first of all assessment and indication of admission. So this is one thing. Okay, so assessment, how will you do that? I said that there are some scoring systems. Okay, there will be some scoring systems that will be a general scoring system, which will tell you mortality and morbidity. Okay, and there will be some specific scores related to a disease.
Specific
This is one
disease.
thing. Then there will be a systemic evaluation. Okay, systemic evaluation, for example, if you want to evaluate a cardiovascular system, there will be certain signs, symptoms. Okay, then there will be certain, like for example, you will be looking at blood pressure, heart rate. SpO2 is also part of cardiovascular system. Then there is ECG. Okay, there will be signs of low cardiac output,
ABGs.
signs of low cardiac output. So your system, that system will be either spontaneously maintained, or you are giving some push by some vasopressor, okay, or inotrope, or pacemaker, or this one, what is that, AICD, okay, or balloon pump. Okay, so like these parameters, whatever you are getting, the blood pressure, the heart rate, the SpO2, the ECG, the cardiac output, either in ICU, because we are focusing focus assessment in ICU. Okay, so we are either these parameters you are getting spontaneously or through some push. So the push will be this one, and this will tell you whether the patient is decompensated, serious, how mortality, morbidity will be told by these things. Similarly, if you want to see the respiratory system, either you will be looking at the journal look, like any cyanosis or something like that, or you will be looking at SpO2. You will be giving looking at how much you are giving FiO2 and how much PO2 you are getting. Okay, so what business you are doing, this is the business, how much FiO2 and how much PO2 you are achieving. So you will be looking at, for example, FiO2, your patient is spontaneously breathing, or patient is on nasal cannula, or patient is on face mask, patient is on reservoir face mask. Okay, patient is on this Venturi mask, or patient is on BiPAP, or patient is on mechanical ventilation. Okay, so giving FiO2 by many ways, and the result you are getting is in the form of PO2. Okay, so when your patient is on ventilator, there are certain things which you are doing. You are giving some PEEP. Okay, you are changing the specific mode of ventilation. That's what we are doing, am I right? And
Yes,
your target is that you get a good PO2. Okay, and you remove CO2. That's what your target is. So if you want to evaluation, again, your answer will be that I will be evaluating on these parameters. There will be any signs of respiratory distress, okay, or failure, and the result will be decrease in PO2 or increase in CO2. Usually this will be happening. Okay, and then the rest of the things will come. Any system will be coming, will be like you will be looking at intake output. Okay, you will be looking at lines or tubings. Okay, then you will be looking at bed sores. Okay, you will be doing some things, because whenever the patient is on ventilator, there is always a chance of VAP. Okay, and VAP will lead to sepsis, and sepsis will lead to multi-organ failure. Okay, so you will be looking at some strategies to prevent. What are different strategies to prevent ventilator associated pneumonia? By the way, we will just discuss ventilator associated pneumonia there and then. Now what will be the factors by which you can prevent ventilator associated pneumonia? Because whenever you are assessing the patient on ventilator, even the patient has no VAP, you will be preventing it. So this is part of your assessment and part of the basic management, that whether you are giving any prophylaxis or prevention or not. Okay, because once
Yes.
it's occurred, the thing will be. What is ventilator associated pneumonia? Because this is a frequently asked question. So what will you answer?
Pneumonia that develops 48 hours after the endotracheal intubation.
Start or even after cessation. Okay,
Yes, sir.
it can occur even after certain hours. You just see the hours, and there are certain organisms for its early onset and late onset. Okay, you can, because it's not possible, I will just try to give you a bit concept. So you can see the organism which are related to early onset and organism which are related to late onset. This is thing. Then what are the risk factors for VAP? Which patient will have more chances of VAP?
Sir,
Like
patients on the extremes of age, patients
immunocompromised.
having chronic diseases, chronic respiratory diseases,
Okay,
those who are not being nursed appropriately in proper positions,
okay,
uh, and previously, if patient is having some kind of resistance to antibiotics,
okay.
or he has got ARDS.
Yes, like
Aspiration.
aspiration. Okay, aspiration and ARDS,
Aspiration,
or
then
and
circuit
patient is
changes.
generalized in sepsis. Okay, so there will be more chances of developing. Actually, these are all friends. ARDS, sepsis, VAP, and MOF, multi-organ failure. They are close friends. One thing occur, it can lead to the other thing. Okay. So now, what are the different strategies for the VAP prevention? Or you in the exam,
Sir,
they will be asking you VAP prevention bundles. So what are those?
yes, sir. Sir,
That's it.
there are certain things which we have to take care. We have to reduce the risk of aspiration. We have to optimize. We have to optimize the.
How will you reduce the risk of aspiration?
Okay, sir. For reduction of risk of aspiration, we will number one nurse the patient in a head up position, in 30-degree head up position.
Head up.
Then the tracheal tube cuff should be more than 20 centimeter of water.
Tracheal cuff should be more than tracheal cuff
20.
pressure. You have to maintain tracheal pressure and don't let
Yes,
it
it
go
maintain.
high, because it will result in necrosis. Okay.
Then we can use the special endotracheal tubes which have the
Subglottic.
ports for suctioning, subglottic ports for suctioning.
Very good. What else?
The chlorhexidine mouthwash.
Mouthwash.
Sir, a sedation-free interval in order to patient breathe itself.
Sedation breaks. What else?
Sir, first we were talking about reducing the aspiration. So aspiration may then there is the frequent changes of endotracheal tubes also.
Avoid.
Also do closed suctioning system.
Avoid. Yes, sir.
Avoid frequent changes in ETT changes.
Endotracheal.
Okay. What else?
Then we have to reduce the organisms, the bacterial culture over there. So for that, number one, we can use special tubes that are lined with silver, I think silver coated tubes.
Okay.
Then we can use, then we have to avoid giving PPIs to patients who are not on significant risk of developing ulcers.
Okay.
And
Positioning.
micro.
Yes, positioning. Positioning we have told, head up.
Then hand
Sir,
hygiene and handling hygiene.
Hand hygiene.
Circuit changes, avoid circuit changes.
Bed to bed nurse. Bed to bed nurse. This is prevention of
Sir, DVT prophylaxis.
DVT prophylaxis directly not related to VAP. How it is related to VAP?
Sir, secondary related to.
Okay, but just concentrate on specific things.
Closed suctioning system.
I'm sorry?
Suctioning system.
What's that? What's that?
Suctioning system should be closed.
I'm sorry.
Social distance.
I'm sorry.
So he's saying closed suctioning system.
Yes, closed suctioning system. Fine, fine. Closed suctioning system. Okay.
Then we have to reduce the time of endotracheal intubation, like we have to extubate the patient as soon as possible. So we should be
Yes, for
monitoring the
that you
patient
have to do sedation
and
breaks.
patient break and daily assessment.
Avoid muscle relaxants. Okay. And then there may be something missed or no.
Also avoid the antacid or PPI only if there is need, is like patient
Needed.
have history of
You
PD.
mentioned.
Yes.
Yeah.
Yes.
You have to
Okay.
avoid.
So these things will be there will be certain factors by which you will avoid. And how will you diagnose VAP?
So the Cps score.
I did not. You go to the scores. Okay. I told you that if you
Sir,
start with the score, believe me, you will be stuck in the problem. There
yes.
will be some risk factor for development, like patient is on mechanical ventilation or things like that. Okay.
Sir,
And the factors which
patient
you
should be
note at the
intubated.
start.
Patient will develop new onset fever.
Very good.
Patient will develop new respiratory changes like respiratory findings like crackles or on chest
Capacities.
X-ray, or a new culture is positive.
And new
Sir,
culture.
increase FiO2, decrease PaO2, changes in
PFA.
X-ray infiltrates.
Actually, now you can tell specific about the score. Okay. There will be,
Yes, sir.
so you can tell to start with, you say that there will be something happening, and then you can pinpoint in the this one. And actually for specifically for bronchoscopic diagnosis, what terminologies they can ask you? One is bronchoalveolar
So
lavage.
specimen brush.
So most sensitive is specimen brushing.
Specimen brushings. Yes.
Because even small amount is there, small colonies, because the colonies are 10 raised power something like that. I don't remember exactly, but the sputum, and then next is bronchoalveolar lavage, and then most specific is this one. Okay. And they may ask you about the colonies. So
Yeah, colonies I can add if you want. In brushing, there is 10 to power 3 is for brushing, you know, and for ball is 10 and 10 power 4, it's for ball, and for tracheal excretion is 10 to power 8 or more than 8.
Yeah, like the concept is that the even the small number of colonies, if they are in specimen brushing, because you are taking exactly at the place you are thinking the source of infection. Okay. And then in
Yeah.
ball you are throwing some saline and pulling it out, so you will find something. Okay. And endotracheal tube, there are more chances of contamination. So is this one sputum, there will be more chances of contamination, so you need more colonies. So this is the concept. Okay. And then you will have empirical antibiotic, but you should be shifting as soon as you get the culture result. Okay. You will
Yes,
be specific antibiotic. Okay.
Yes.
And rest of the parameters will be same for like ARDS. Okay. So like as we were saying, because why I shifted to these topics first, because evaluation may take a lot of time. So that's why I want to finish these 2-3 topics quickly, and then we will finish the rest of the part which I was telling you, because that needs more time. I have done it before, so you can review in the playlist of so what is similar. Another friend of VAP is ARDS. So what is the diagnostic now? Sarish, you can tell what is the diagnostic criteria for ARDS?
Yes, sir, bilateral opacities.
Zishan, let her speak, please.
Sir,
Yes.
basically, ARDS is diagnosed on basis of onset. The duration is less than a week or
Okay.
less than 14 days. And there is bilateral opacities on the chest X-ray. And there is bilateral pulmonary infiltrates basically found in the X-ray.
Not only X-ray. Not only X-ray, also CT scan. Okay. Because if you will say only X-ray, this is not the criteria, because they change in Berlin. the Berlin people will be angry with you. Okay.
Radiographic.
Because before they say chest X-ray, now they have changed the word to radiographic. Okay. So now either in CT or chest X-ray, and there is acute development of new
Of edema. Yes, sir.
opacities. Okay. Diffuse opacity.
Opacities, bilateral opacities
And
on the chest X-ray.
There is some inciting factor. What are the inciting factor which can cause ARDS?
So what are the
Factors which can lead to ARDS? Transfusion reactions. Other than
yes, okay.
other
Yes,
than
sir.
trauma,
Pancreatitis.
pancreatitis. There are so many
Yeah,
factors.
you can divide it as pulmonary,
Pulmonary
extrapulmonary, and
factors
pulmonary.
and extrapulmonary.
And-
Very good.
Okay.
Yeah, okay. So there are certain factors you can say, and try to memorize 3-4 common, as Jamil told, pulmonary and extrapulmonary. Okay. So how will you assess the severity? Because there was a concept of ALI before. Okay. So acute lung injury, and now it is changed to mild ARDS and severe. Okay.
Severe.
So on the basis of PF ratio. So on the basis of
PF ratio.
less than 100,
ratio.
less than 100 to 100 to 200 and 200 to 300. That's all.
300.
So PF ratio you should be knowing. They can ask you to calculate. So for example, just quickly, if for example we are having 0.2, if 0.21 it is 0.2, and we have a pressure of 100, so our PF ratio is 500. Okay.
500.
Okay.
Okay, sir.
I have put it in the wrong direction. It is 100 pressure on FiO2 0.2. Okay. So it is like that. So 100 divided by, so now if you have a patient who having 100% oxygen and he is getting 100 PO2, so it is 100 by 1. So PF ratio is 100. Okay.
Okay.
So this is another thing. And now the lung protective strategies. How will you give? What are the factors you will be looking at? Yes, please.
It's an ARDS net protocol.
Yes. Please.
Ventilator protocol.
Yes. Wow. How you do it?
The low tidal increase PEEP and increase FiO2.
No, not increase FiO2.
Then?
Try to use minimum FiO2.
Okay.
So actually,
Permissive hypercapnia.
Permissive hypercapnia. Okay. So actually, you have to if they ask you what is ARDS net protocol, if you tell in that way, you will not be failed. Number one, you are using predicted body weight to calculate the tidal volume. You are starting with 4 to 6 ml per kg. Yes, 4 to 6 or 6?
Ideal body weight. It's 4 to 6.
It is predicted body weight. It is predicted body weight. Okay. You can reconfirm it. It is predicted body weight. And you are starting with low tidal volume, and then you are looking at plateau pressures. Okay. You are targeting low plateau pressures, and as soon as you are getting the results, you are modifying your settings. Okay. So you will not let airway pressures to go up, because that will cause barotrauma. Okay.
Barotrauma.
So your main target will be that you will be trying to reduce. So you have to titrate tidal volume, plateau pressures, and you will take help of PEEP to achieve PO2. Okay. And whenever you are giving PEEP, the blood pressures can fall down. So you have to take care of the blood pressures. And you are allowing, if all these fails, you will be allowing some permissive hypercapnia. Okay. So less you can read about it, but the basic concept, if you tell like that you will be starting with low tidal volume, you will be trying to limit the plateau pressures. And if you are getting good result, you can increase the tidal volume to 6 to 8. Then if it is failing, Next step, you are adding PEEP. Okay, and then rest is the thing. So that is important for management of air. If all these factors fails, the rest of there are some things like nitric oxide, okay, like intermittent proning, okay, and if even
And
that
then
ECMO, okay.
ECMO.
And actually the thing is that in ARDS even you need to give some muscle relaxant, okay, because if there are increased airway pressures you are not handling, you can give muscle relaxant. And then there is role of steroids in fibroproliferative phase, okay, in which there is fibrosis, chances of fibrosis. Dr. Junaid, if you can close your camera, please. Yes, okay. So okay, so ARDS, if they will ask you what is ARDS, how it is diagnosed, how will you quantify the severity, and then how will you monitor, what are the factors you will be, and actually some of the things are the same. Now we will come to the conclusion that even in ARDS, the patient should have, now in addition to lung protective strategies, all the generalized thing which we discussed. You can say that as a whole, you have to do all the things. After telling these things, then you can tell positioning and thromboprophylaxis, and we will just look into the sepsis shortly. So next thing which you are evaluating as well.
I just want to add also, I think it's in the management. Gradually, first this lung protective strategy, then you go to inverse ratio.
Yes.
And then,
yes, inverse ratio.
Gradually. And
gradually,
then proning, nowadays, proning is recommended then more than 16 hours also. Before it was less than 12 hours and they told that it's less effective. And if you do the proning for 16 and more than 16 hours, then it is effective.
Yes. Okay.
And then the role of nitric oxide and high frequency, it's also controversial.
High frequency,
but
yes.
no still are using it.
High frequency jet ventilation or high frequency oscillatory ventilation. Okay.
Oscillation, yes.
So
Yes,
these
still
are doing
using
it. So now next thing is related to another friend is sepsis. Okay. So in the sepsis, the terminologies we should be knowing are what is septic shock. And Zishan loves this topic. So what is SOFA scoring and what is SIRS score?
Sir.
Okay, Zishan will tell.
Sir, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection.
Okay, then septic shock.
And septic shock is sepsis-induced hypotension. Despite fluid resuscitation
and needing vasopressors, okay,
vasopressors to keep MAP above 65.
And actually they asked this in 2021, they add this SIRS score. So I don't know about it, read about it. I will share the article, you will find it. If you, Zishan, if you can remember, you can tell it.
SIRS is very simple. SIRS has 4 components. If these are present, we call that this is SIRS. It has temperature less than 36 or more than 38. It has heart rate more than 90, tachypnea more than 20, and or the PaCO2 is increasing, and white blood cell count is either less than 12,000 or more, less than 4,000 or more than 13 or 14,000.
Okay, so actually it is the same what was there before. Now they have put a good baby and put a name. So that's,
yes, sir.
These people are doing it and they are just torturing the students. It is the same thing which I read maybe 10 years ago. It's the same thing, but they've just put a label. Okay, so now, so actually don't worry about it. Usually they should not fail you on this question, but they just ask this question to check your nerves. So stay calm and just relax. They will not fail you. The things which are failing are what you will do if you have a suspected, you see that there is something going towards us. What was the difference between Q SOFA and SOFA? That SOFA was needing some investigations. So they put it Q SOFA just to avoid delay in diagnosis. And if any patient have any score with QSOFA, you will start resuscitating the patient, ABC, okay, and then you will take the blood cultures, okay, and you will you will take ABGs to see the lactate, okay. You will be starting fluid resuscitation, okay. Fluid resuscitation.
Yes, if you allow me, I can add this. There is QSOFA and SOFA. QSOFA is for screening score, and it's only basis on the clinical things. There are three: HAT, HAT means hypertension, blood pressure less than 100, and A for
Altered ventilation.
altered mental status GCS less than 15, at T for tachypnea, respiratory rate more than 22. It's in emergency or when you first time see the patient to screening the patient. That patient might be have sepsis or septic shock. But so far there is clinical and plus labs. It's for
more detail,
for the admission,
more detail,
for more detail, and it's more for the prognostic. What is your treatment? Is going well, or so worse, or you have to modify your treatment?
Yes. So after ABC, you will be taking the blood cultures and it start antibiotic, okay, and then you will take the lactate and you will follow the lactate and you will start the fluid resuscitation. You will go up to 20 to 30 ml per kg according to the response. And another for if you have a patient,
20 to 30 is just the starting one.
yes,
and we can go up
still
according to response.
you will start it and you will say that this is the protocol, but usually the thing is that you have to look for this, always you have to look for the signs of overload, because if you have a patient with cardiac failure, you have to modify it accordingly, okay. You will be starting the fluid and then you will see the response. If you want to if patient is responding to the fluid, you will give more and more, okay. This is one thing. And then you will start the vasopressor. So the vasopressor of choice is norepinephrine, okay. And you will start norepinephrine, and then you will be putting the CVP, or and then you will be following the
Pulse pressure variation.
no CVP. You will do the oxygen, venous oxygen saturation, okay.
Central venous oxygen.
Central venous, okay, because the more accurate is mixed venous.
Still some examiners still ask about the bundles. 1 hour bundle, 3 hours bundles.
This is 1 hour bundle. 1 hour bundle.
Yeah, in 1 hour, you take the blood sample for lactate and blood culture. Give empirical antibiotic and start the infusion. It's in 1 hour. In 3 hour, what is this? You have checked the response of the fluid, and because in first hour it's difficult to finish your fluid bolus, but within 3 hours
Actually,
you
in the 2021 guideline, they have changed it. The fluid is to be given within 3 hours. It's not in 1 hour now.
That's no. You have to start the fluid with first hour.
Start the fluid.
You have the
And we
finish
have
the
to
fluid
complete it
within 3 hours bundle. Not later than 3 hours.
Remember, Jamil, we cannot cover 100% examiners. We can cover 99% examiners, and 1% will leave on our luck. Okay, so this 1 hour, 3 hour bundle can confuse people. To both of you, I will suggest this.
Actually, they ask.
No, you are right. You are right, but you will say again your answer if you are asking. If you are telling like this, that your approach is again airway breathing circulation, and then you will immediately take the blood cultures, start fluid resuscitation, do ABGs, do lactate, and then you are gradually seeing the response, and within like time is also passing by. So 1 hour and then 3 hours. It's like that. Okay.
Yes.
You are right that they are asking 1 hour what you are doing. So this is the answer. 1 hour you are doing this thing, and then you are finishing it in 3 hours, as Ishan is saying. There is no difference in what you are saying and what he is saying. Okay. But don't confuse yourself. That approach should be the correct one. And then you are starting the vasopressor. Then you say about mixed venous or central venous oxygen saturation. You should have a specific target for it. Okay. 65 or
They asked when you will start the inotropics or vasopressor. They asked when you give the first bolus and the blood pressure not improve, mean arterial pressure more than 65 for the first bolus, then you will start, the inotropes.
Yes, that's what actually you will see the fluid response. If the patient is responding to the fluid, the blood pressures are improving, perfusions of low perfusion are improving, then you will continue it. If it is failing, then you will next step is vasopressor. Okay, that's what you are saying. Am I right?
Yes, sir.
Okay, so you are adding vasopressor, and now again you are trying to achieve the mean arterial pressure. You are trying to get the mixed venous oxygen. Of course, pulmonary artery catheter is not being used now, so you are using this central venous oxygen saturation, and then you are also monitoring the urine output. Okay, and then at the same time you are having, you can say that you will be involving multidisciplinary team. You are trying to see the source of infection and everything. And the next step at the same time of you are have this vasopressor is not responding, and you see any element of cardiac failure, then you will be adding inotrope. Okay, inotrope, and then what else? Inotrope will be dobutamine. Okay, vasopressor, if one vasopressor is failing, then you can go to vasopressin or epinephrine. Okay, so if it is not responding to these things, then you will consider hydrocortisone. Okay, and then DVT prophylaxis, blood pressure, blood sugar control. Okay, and as I told you, urine output, you will trying to monitor the urine output. So this is the package deal with what. But you know why people are confused in 1 and 3 hour, that the first thing immediately, as soon as you find something in QSOFA, you will start the management. You will send the blood culture. You will send ABGs. Okay. Blood culture. You will start fluid resuscitation, and you will give antibiotic. This is what is the immediate management in addition to ABC. Okay, so this is how, if you tell, inshallah, you will not fail, I guarantee you. Okay, so this is the concept of sepsis. And sepsis, the rest of the things, as Sarish was telling, DVT, glycemic control, how much the blood sugar should be? Liberal, 120 to 180. Okay, what else? ARDS protocol will also
be there. I just want to add, always get the general care like fast hug, impact, and specific management.
Yes.
In every case, you have to tell them also, I will do the general care like fast hug, and I will do the specific.
Just a second, fast hug we will just discuss. F is for feeding. Okay, A is for analgesia. S is for sedation. T is for thromboprophylaxis. H is for hemodynamic.
Head elevation.
Head elevation, yes.
Hydration.
You can say hydration as well, okay? Because this mnemonic is just to help you out. Even hemodynamics you can also say, okay?
T for
and U for
ulcer prophylaxis.
Ulcer prophylaxis. Okay, and G is for glycemic control.
Glycemic control.
But please, I request you, don't use this fast hug in front of the examiner. Even if it is in your mind, this is not creating a good impression. Okay, if you are telling fast hug, but don't tell that, sir, there is a formula for management. Okay, this will not create a good impression for you. So feeding, analgesia.
No, I am again, they want to listen this word because
they want to listen. Okay, you have just recently passed, but I actually, you know, if you, for example, if you want to pass from these words, I guarantee you, you are about to fail, believe me. Okay, so because your words are authorities, Jamil, remember one thing, These are overstated things. Okay, you pass exam because you had clear concepts. I can guarantee you that no examiner will fail you if you don't tell the formula fast hug. This is just
No,
in
no,
the
no.
minds. No,
Yeah, yeah.
I don't accept.
Sorry for I don't want to. Actually, it's a what you say it's mentioned in the books, and it's not by mnemonic by any person. It's literature words, you know. And if you just tell I do the journal management as a fast hug, and I will do the specific management,
Okay.
and then you know if you just save the time, you just tell them I do the journal management as a fast tag, and I do a specific management for BAP and anything you know else, and they know. And it's not the by any student mnemonic, it's from the literature, from the article, any book. IC books also is mentioned as a fast tag.
Okay.
But I tell them even fast hug in bed, you know, there isn't further
What
you
is
know,
bed?
and yeah, they want to list the further what that means in bed, you know. Then
What is in
I
bed?
told them in the mighty bed.
What is in bed?
In I for indwelling catheter, you have to take care of the indwelling catheter, and for NG, if there is NG, you have to take care about the NG.
Okay.
And bed for there is a break of seditions. E for there is enteral care, means if you want to do stop for prokinetics, and B for you also have assess daily for the delirium.
Delirium. Okay. Okay. So I am telling all these things without mnemonic, and you are telling with mnemonic. So we have a consensus guidelines now. Okay. But mnemonic, of course, help. Okay. Mnemonic also, of course, help. You are absolutely right that maybe this is mentioned in this anesthesia update. Anesthesia update 2012. It is mentioned this fast hug. Okay. So, but I'm just telling generally that these mnemonics can help you. But if you don't know the basic concept, you may be stuck. You are absolutely right that they want to know, and it is actually these mnemonics are helping you. You will not forget it. Okay. But actually, this is all general care. You are absolutely right. So what was for I is for indwelling catheters. Okay. So as I told in the start that we will just some aspects I will tell you, and then we will finish our discussion for nutrition. And these catheters, there is like either it is Foley's or NG, okay, or there is gastrostomy tube, okay. There may be some other lines like CVP, okay, and there may be dialysis catheter. What else? Anything else? So you have to take care of them. And nutrition is very important. It is always better to start early nutrition, okay, and always enteral nutrition is better than parenteral nutrition. Why? Because it is more physiologic, okay, and it is avoiding the bacterial translocation. Okay. Okay, Jamil, are you here still?
Yes, sir.
Yes, sir. Yes, sir. Ideally is oral. If non-oral, then enteral.
Yes.
And there is different routes. There's through NG, through OG, and there is gastrostomy and the ileostomy tubes. You know, you can start this in. And it's more physical.
And then another thing is that it is better to give in infusion, okay, than
continuous, yes.
Bolus. Or it is better to give in infusion than
continuous than better than bolus,
because there will be
less
more chances of aspiration.
Aspiration.
Aspiration, so it is better. And then another thing will be that you have to start early, and when you start, you have to be ready for refeeding syndrome. Okay, so refeeding syndrome is that when you start immediately, there is increase in insulin, and there are chances of hypokalemia. Okay, because insulin will be released and it will push ions inside. So there will be severe weakness and patient can go in respiratory failure. Okay. So whenever you start, you have to look for it. So some few words about the component. There is fat, there is protein, there is carbohydrate. There are essential elements. Okay. So caloric, usually it is calculated by 20 to 30 ml per kg. Okay. This is basal energy expenditure. Okay. When the patient is NPO, then first of all is with the basal energy expenditure, and then when the patient is having the feed, then it is resting energy expenditure. You multiply it by 1.2. Like, just to try to, I will just try to give you an idea. So if you calculate 70 kg with 20 to 30, so it will be 2100, okay, kilocalorie, and then you will multiply by 1.2. Okay, so then there will be, third thing will be stress factor. Okay, according to the surgical stress, it will be either 1.2 to 1.4, 1.6. So you will multiply the number.
0.6 for surgery.
Yes, for severe stress, usually ICU patients ventilated, this is 1.6. So this number which will be achieved, you will multiply that number with 1.6. So that will roughly, for example, I'm just trying to simplify it. For example, you get a figure of 3,000. Okay. Now what you next step will be that you will be calculating the fluid requirement according to the 4:1 formula. So for example, you get, for example, 3 liters. Okay. So you will just try to divide these in, you will try to divide these 300,000 calories in this 3,000 ml fluid. Okay. So this will be one thing. And then another thing is that protein, usually you will spare the protein. Okay. You will not calculate the calories for protein. Okay. You will take protein separately, 0.5 to 1.5 gram per kg. Okay. So usually roughly, for example, if you are taking maximum, so it is around 100 gram of proteins, and usually we have 10% amino oil. Okay. So which you will be replacing protein, and your target is to avoid negative nitrogen balance. I had discussed this thing before. I'm just trying to give a quick review about it. So the rest of the calories you will calculate by 30 to 40% of, and
40% of fats.
Carbohydrate. Okay. So there will be lipofundin. There is one preparation called lipofundin. So it will be according to the percentage, and you can have 50% or 25% of dextrose according to the volume. And usually in ICU, there is nutritionist. He will be checking out if you have a patient with renal problem, he will be decreasing the proteins. Okay. If you have a patient with the respiratory problem, you will try to reduce the carbohydrate. Okay. So that is how you will calculate it. You will make, usually there is a prepared feed containing every required thing, and then you are giving it slowly. Okay. Through peripheral line, CVP, or there is either through TPN or as peripheral parenteral nutrition through PIC line. Okay. So this is the basic concept of nutrition, and I have just tried to cover the general care, rest of that again respiratory things.
I have a question, sir.
Yes.
Sir, a question is being asked: how will you assess the nutritional status of a patient in ICU?
Yes, there will be some certain this what you say.
Is the global subjective assessment is the answer for this thing?
Yes.
For this question.
Yes. Who was answering? Yes, Harish, please.
Basically, nutritional status in ICU is measured by 4 methods, and basically it is as A, B, C, D. Anthropometry. In anthropometry, we used to say the patient mid-arm
Those,
circumference.
Dr. Sarish, those are for the malnutrition. Those are not specifically for ICU patient.
No, but
So
When
this
you are
is this
mentioning
may
No,
be
no,
used.
no. She's right.
Okay.
She's right. This is the
You can
proper
use it.
ABC bundle and
Malnutrition,
thermography.
you know,
So
Zishan.
this same will be used in ICU also.
Yes, same
Yes.
way.
Yes.
Journal principle never change. Remember one thing: don't complicate yourself. This is to assess
I'm
nutrition.
just clarifying myself, sir.
No.
Because
You understand my point that simple things will always remain correct. You will say that you will be assessing, you will be calculating the nutritional requirement, you are giving it, and then you are constantly assessing it, that you are
yes,
in
sir.
good or bad, because there will
Right.
be some tests.
The ABCD one and the subjective global assessment one will be come first.
Exactly.
And after
Yes.
that, for ICU patients, we don't we also have to mention about the nitrogen balance?
Yes, nitrogen. I told you in the targets.
Yeah.
Nitrogen balance.
Sorry for interruption, sir. Sorry for
Yes.
interruption. Just now.
Electrolytes.
We can use the protein also as a we will use the protein as a energy the expenditure also. And it was the old concept that we give the protein just to make a negative nitrogen balance, but nowadays they use in total calories also, and it's 4.75, I think, you know, the 1 gram of protein gives the calories.
Yes,
And you will calculate
9.1
30%
for fat, 9.1
fat,
for
yes,
fat,
and 3.75 for the glucose, and you use the 30% of your calories
just
from
a
the
second,
protein.
Jamil, just a second, because I just missed few of the things. So it is 9.1 kilocalorie per
That's
gram.
per gram.
Okay.
Per gram.
Gram for
Because
the
you have to
fat.
calculate the calories accordingly, and 3.75 kilocalorie per gram.
For
Okay.
glucose, carbohydrates,
And around
yes.
4
around 5. It's 4.75
5,
or
I
5.
think 4.9 or 5, you know, for the, or 5.3, sorry,
Proteins.
5.3 for the protein to be
carbohydrate.
very
You know,
precise. 5.3.
Jamil, it is usually it is said that you will not calculate protein for the total calories to prevent nitrogen balance.
sir.
Again, I will listen. If you have a negative nitrogen balance, you will your aims are to prevent negative nitrogen balance. Your aim is to give calories. If you want to add it, you can add. But if you require extra proteins, you can keep them separate, or you can put it. I have, because we are not doing ICU. So if something new in data, of course, they may be asking this question. Okay. So this is again, if something is new, you can tell that there are some changes which are being done. But usually that's what we studied. It's something new, which is something new for me as well. Okay. Okay. So we are just concluding what I have told you: assessment, and in assessment, general assessment, and all the parameters which we use, this fast hug and everything. And we just discussed some things about cardiovascular system, something about respiratory system, conscious system. Of course, I am not able to cover delirium. I wish to cover it. Okay. And the respiratory is the renal replacement therapy support. Okay. And specific organ failure like pancreatitis. Okay. Abdominal compartment syndrome. Okay. So we will try to have another session, inshallah. Actually, these I just.
And the next session, that let the Sarist explain, tell the nutrition assessment ABC bundle, because it's also important. Sometimes they ask about A for anthropometry, B for biochemistry or BMI, C for clinical, and D for, I think,
Before is dietary changes that is
dietary
related to
changes.
histone.
Yeah, in 24 hours. And then there is global assessment. Is like mnemonic is the MOLA, means the mass, muscle weakness, so for edema if there is, and loss of fat, and A for there is ascites. These shows about the nutrition status.
Albumin level. Okay.
Yeah.
Albumin level and electrolytes.
It's for B.
Sodium,
Yeah, it's for B
calcium,
for the biochemistry.
calcium.
A, B for biochemistry and BMI. In biochemistry is pre-albumin and albumin.
Okay, what is the formula? Please say it again. I will just write it.
ABCD and then global assessment. A for anthropometry, B for biochemistry,
Okay.
pre-albumin or albumin. Sometimes they include the ferritin also there in the status.
And albumin, these three.
Yes, and
yes. So this is to assess the nutritional status. Okay. So
Yes, sir.
anyways, I just try to cover as much as possible. Remember one thing, these all things are correlated. Okay. So if you have, because that's from where I started. So if you have the general concept is clear, you can tell these things, and always there will be some margin for you to cover your answer. There are some topics which are important: delirium, renal replacement therapy, pancreatitis, abdominal compartment syndrome. They ask to me once upon a time ICU admission criteria, discharge criteria, how to set up an ICU. Okay, what are the requirements for ICU? What are the, like, how many beds per beds of hospital? Okay, and then this one, how much sockets? There is a ICU administration. So this question you should be knowing. What are the advantages of ICU physiotherapy? Okay, this question may be asked, and there are certain teams. One team is RRT, rapid response team. This is related to ICU because this is being run by the ICU people, and they are trying to avoid ICU admission. Rapid response team, and they are working on this early warning signs. Okay, rapid response team works on early warning score, and this is if it is pediatric, it is PEWS. In maternal, it is MEWS. Okay, so there are certain parameters. It is activated by the nurse, and there is a team which is coming and trying to avoid the ICU admission. This is one thing. Then there is one code blue team. They can ask you about it. I cannot tell you in detail. There is a code blue team for the cardiac resuscitation. There is one team, outreach team. Okay, critical care outreach team. The patients who are being discharged from ICU and are getting care in the step down. They are also in the wards. They are getting the care like suctioning or any advice there. There is some concept of outreach team, and there is some people who are
Rapid response team and outreach team are different.
Yes, rapid response team is different, and outreach team is different. Outreach team is for the patient who are admitted to ICU and now in the wards, and they are providing some care to those patients. Okay, this is critical care outreach team. So these are the teams which you should be knowing: administration, rapid response team, code blue team, critical care outreach team, and some of the topic which we couldn't cover. Maybe we will try to have another session later on. Okay, so rest of the topics, these topics actually I have discussed before as well. So if anyone is interested, they can go to the YouTube channel, and you will find related to ICU a number of discussions. Okay, so you will be benefited. Actually, I am sorry because some of the people, they are going for some exam. So because my main aim is to help out anyone, and remember any other people, because we have a lot of friends from different countries. So I'm thankful to you that you are giving me honors to listen to my discussion. This is one thing. And if any one of you want any help, you all are welcome. Okay. So thanks a lot, and thanks to Jamil because he recently passed the fellowship exam, and it's honor for us for him to be with us, because usually the people who pass the exam run away and never come. Okay, and Jamil, your help will be more helpful. I will be really thankful to you because after a few days I will go back to the detailed discussion of one topic which we do. Okay, so your help will be of utmost.
Okay, sir, you are most welcome. If you want to discuss about the ICU,
actually they have exam.
I
Thanks all of you for your presence, and we will meet tomorrow inshallah, same time. Thank you. Bye bye.